Hey everyone, and welcome to a deep dive that could actually change your life, or maybe someone you love's life.
Hmm.
We're going to be tackling cardiac resynchronization therapy,
Okay.
better known as CRT.
Right.
And trust me, this isn't just for medical people or whatever.
Yeah.
If you've ever felt that terrifying squeeze of heart failure,
Oh, yeah.
or watch someone you love struggle for every breath you need to understand this breakthrough,
Right.
we're going to walk you through like how CRT works.
Yep.
It's magic.
Okay.
The trials that proved it's not sci-fi,
Hmm.
and the guidelines doctors use to see if it's right for you.
You got it.
And a huge thank you to the folks at London Heartbeat Z Academy who make this deep dive possible.
Absolutely.
They're an amazing resource for anyone wanting to learn more about cardiology with over 150 popular courses to choose from.
Wow.
You can find them on Facebook, Instagram, Spotify, and YouTube.
Nice.
For free updates and insights, just search London Heartbeat Z Academy.
Great.
Okay, so let's unpack this, starting with a harsh reality. Heart failure is on the rise.
It's a global problem.
The numbers are grim. It's a global issue, and some people face a 50% chance of not making it past 5 years after diagnosis.
That's right.
Even with all our, fancy meds and stuff, heart failure is a tough opponent.
It really is.
Yeah, so that's why CRT is such a beacon of hope.
Exactly.
It came on the scene in the mid-1990s,
Uh-huh.
and it's been changing the game ever since.
Yeah, definitely a game changer.
So if heart failure is on your radar in your life in any way,
Yeah.
this deep dive is for you.
Absolutely.
So what is CRT?
Okay, good question.
Imagine your heart toward this powerful pump, but the signals telling it to squeeze are out of whack.
Right.
Different parts are contracting at different times,
Mm-hmm.
making it work way harder for less result.
Yeah.
CRT is like hitting the reset button,
Hmm.
getting everything back in sync so your heart can pump efficiently again.
Perfect analogy. That's exactly it.
You nailed it. That's the core problem, ventricular dyssynchrony.
Yeah.
It's like trying to row a boat when everyone's pulling oars at their own pace.
Yeah. Uh-huh.
I love that analogy.
CRT steps in as the coxswain,
Yeah.
yelling, "Stroke, stroke," to get everyone working together.
Perfect.
But there are different types of dysynchrony, right?
Yes. All right.
I'm already getting a sense of how complex this can be.
You're right. It's not one size fits all.
Okay.
First, we've got electrical dysynchrony.
Okay.
Think of it as faulty wiring in the heart.
Okay, so like a short circuit or something?
Not exactly a short circuit, but the electrical signals telling the ventricles to contract are delayed, and we see this as a prolonged QRS complex on an EKG.
Yeah, EKG.
Ah,
Those squiggly lines we've all seen in medical dramas.
exactly.
So this electrical delay is a red flag that something's off.
Exactly. Then there's mechanical dysynchrony,
Okay.
where we actually see different sections of the heart contracting out of sync.
Hmm.
Some too early, some too late, even if the electrical signal looks normal.
So even if the wiring seems okay, the actual muscle movement could still be messed up.
Precisely. And both types of dysynchrony lead to trouble.
The heart can't pump efficiently, there's extra stress on the heart walls, and problems with the heart filling properly. It's a downward spiral for your heart's health.
Wow, that paints a pretty clear picture of why this matters.
Yeah.
So how do doctors even detect these dysynchrony issues?
Echocardiography is our go-to tool.
Okay.
Think of it as an ultrasound for your heart.
Okay.
It lets us visualize the heart's chambers and valves in action, spotting those subtle timing differences between the ventricles or even within the left ventricle itself.
So it's more than just like a standard echo?
Yes, it is.
There are specific techniques to pinpoint these problems.
You bet. There's M-mode,
Okay.
a basic view for timing pulse tissue Doppler, which tracks the speed of heart muscle movement,
Okay.
and even high-tech options like color tissue velocity imaging and 3D echocardiography that give us even more detail.
Sounds like a whole science in itself.
It is a very specialized area.
I'm guessing the accuracy of this assessment is crucial, right?
Absolutely. It determines whether someone is even a good candidate for CRT and helps guide how the device is implanted and programmed.
Okay, so now we know how doctors spot dysynchrony, but back to the why of CRT.
Okay.
If the heart is at a sync, how does this therapy get it back on track?
Imagine CRT as a conductor bringing harmony to the orchestra of your heart.
Okay.
It sends out perfectly timed electrical impulses, getting those different parts of the left ventricle to contract together.
Uh-huh.
This teamwork makes your heart a power pumper again and helps it relax and refill with blood more effectively.
So it's like CRT is giving your heart a rhythm makeover, right?
Exactly.
Making it a stronger pump and allowing it to take a deep breath and refill.
Exactly. And that translates into real-world benefits.
Nice.
You breathe easier, you have more energy, and you're less likely to end up back in the hospital or worse.
That's incredible, but CRT wasn't always around, right?
No, it wasn't.
How did we get to this point where we can literally resynchronize the heart?
It's a fascinating journey, really, a story of scientific discovery. We'll explore some of those groundbreaking trials, starting with PATH-CHF back in 2001.
What?
It was a small but promising study that hinted at the potential of biventricular pacing, the foundation of CRT.
Okay, so PATH-CHF planted the seeds. What happened next?
Then came MUSTIC SR, focusing on folks with heart failure and atrial fibrillation,
Okay.
another rhythm problem where the heart's upper chambers beat erratically.
Right.
This trial looked at how CRT affected their walking ability and found some pretty impressive improvements.
So the evidence is starting to build, but I imagine we need those larger studies to really cement CRT's role in heart failure treatment.
You're right, and that's where the Miracle trial enters the scene.
Okay.
This was a game changer, a huge study that put CRT on the map.
Okay.
It involved patients with severe heart failure, and the results were remarkable.
Really?
CRT significantly improved their heart function quality of life and lowered the risk of hospitalization.
Wow, Miracle really lived up to its name.
It did.
Showed that CRT could be a lifesaver.
Exactly, but the research didn't stop there. The Miracle ICD trial took things a step further.
Good.
Comparing CRT alone to CRT, combined with an implantable cardioverter defibrillator, or ICD.
Okay.
This device acts like a bodyguard for your heart, delivering a shock if a life-threatening rhythm problem occurs.
Gotcha.
Adding an ICD to CRT further reduced the risk of death.
So now we're seeing that CRT can be used in different ways and combined with other therapies for even greater benefit.
Precisely, and the research kept rolling. The companion trial, for example, was massive,
Oh.
involving over 1,500 patients.
Okay.
It confirmed the power of CRT in reducing both hospitalizations and death from any cause.
So that's pretty definitive.
It was a landmark trial.
Yeah. Wow. Each trial seems to build on the last, adding to the evidence for CRT.
Absolutely. The CARE-HF trial further cemented CRT's place in cardiology
Okay.
by showing it could actually reduce mortality in folks with moderate to severe heart failure.
Okay, so by now it's pretty clear that CRT is a powerful tool in the fight against heart failure. But with all these positive trials, how did doctors start using this information to make decisions about who should get CRT?
That's where clinical guidelines come in.
Okay.
Think of them as a roadmap for doctors developed by experts who review all the research and offer recommendations on how best to use a particular therapy. For CRT, the 2021 ESC guidelines on cardiac pacing and CRT are essential.
So these guidelines help translate complex research into practical treatment decisions.
Exactly, and they get pretty specific about who is most likely to benefit from CRT.
So let's talk about indications. Who are the ideal candidates for CRT?
One of the strongest indicators is for patients with heart failure who also have a heart rhythm problem called left bundle branch block, or LBBB.
Okay.
It basically means there's a delay in the electrical activation of the left ventricle leading to that dyssynchrony we talked about.
So heart failure plus LBBB equals a pretty good chance of benefiting from CRT.
Well, it's not quite that simple. Doctors also consider the severity of the heart failure, the patient's symptoms, and their overall health, but LBBB is definitely a key factor.
What about folks with atrial fibrillation? That erratic heartbeat in the upper chambers of the heart, can they benefit from CRT too?
That's a great question because atrial fibrillation adds another layer of complexity.
Okay.
Remember, CRT relies on those signals from the upper chambers to trigger the pacing in the ventricles.
Right.
With atrial fibrillation, those signals are all over the place, making it harder for CRT to work its magic.
So it's not as clear-cut for patients with atrial fibrillation.
Right. But there's growing evidence that CRT can still help these patients, especially if certain strategies are used to optimize the therapy, like ablation of the AV node.
Hold on, ablation, what does that involve?
It's a procedure where we use heat or cold energy to create tiny scars in the heart, essentially blocking the abnormal electrical pathways that are causing the atrial fibrillation.
So by tackling the atrial fibrillation, you can make CRT more effective.
Precisely, but the decision to ablate or not is complex and depends on the individual patient.
Now, you mentioned something earlier that's got me curious.
Yeah.
Narrow QRS complex.
Yes.
Didn't she say a prolonged QRS complex was a sign of dyssynchrony?
Right.
So what's the deal with narrow QRS and CRT?
This is a great example of how cardiology is always evolving.
Okay.
Traditionally, CRT was mainly for patients with a wide QRS complex
Uh-huh.
because it was considered a reliable sign of dyssynchrony.
Okay.
But now we're recognizing that some people with a narrow QRS might still have significant dyssynchrony that could benefit from CRT.
Wait, so even if the QRS looks normal, there could still be underlying problems?
Exactly. And this has sparked research into using CRT for patients with a narrow QRS complex. The Rethink-Q study looked at this very question, and while it didn't show a huge benefit in improving exercise capacity, it did suggest that certain subgroups with a narrow QRS might still get a boost from CRT.
So more research is needed, but it highlights that individualized assessment is key. The guidelines are helpful, but the final decision to implant a CRT device depends on a thorough evaluation of each person's unique situation.
Absolutely.
Speaking of which, before we get too far ahead of ourselves, let's pause for a moment to give a shout out to the amazing folks at London Heartbeat Z Academy,
Yes, they're great.
who've been instrumental in making this deep dive possible. They're a fantastic resource for anyone wanting to learn more about cardiology, with over 150 popular courses to choose from.
Wow.
You can find them on Facebook, Instagram, Spotify, and YouTube for free updates and insights.
Great.
Make sure you subscribe so you don't miss any future discussions like this one.
Absolutely.
Now back to CRT. Let's say someone does meet the criteria for CRT. What happens next?
Okay.
Walk us through the actual implantation procedure.
All right, picture this. The CRT device itself is similar in size and shape to a pacemaker.
Okay.
It's placed under the skin, usually just below the collarbone. But here's the key difference. A traditional pacemaker has leads in the right atrium and right ventricle,
Okay.
while a CRT device has 3 leads.
3 leads. Okay, I'm intrigued. What are they all for?
The first lead goes into the right atrium, just like a pacemaker.
Okay.
It's like a scout sensing the heart's natural rhythm and delivering pacing impulses if needed.
Okay, that's 1 down. What about the other 2?
The second lead goes into the right ventricle, also similar to a pacemaker.
Okay.
It paces the right ventricle and monitors the heart's electrical activity.
Okay, so 2 leads are familiar territory. Now, what about that crucial third lead that makes CRT special?
This is where things get really interesting.
All right.
The third lead is threaded through a vein called the coronary sinus, which runs along the back of the heart.
Okay.
This allows us to position the lead on the outer wall of the left ventricle, targeting a specific branch of the coronary sinus that supplies the area we want to pace.
Wow, that sounds incredibly precise. How do they even find the coronary sinus and make sure that lead ends up in the right spot?
It takes a highly skilled electrophysiologist,
Okay.
a cardiologist who specializes in the heart's electrical system. They use X-ray imaging called fluoroscopy to guide the leads into position.
I bet navigating those veins and getting everything perfectly placed is quite the challenge.
It is the anatomy of the coronary sinus, and its branches can vary quite a bit from person to person, so it can be like threading a needle in a moving target.
Oh, wow.
But skilled electrophysiologists are masters at this delicate procedure.
Okay, so just to give everyone the big picture, the whole CRT implant procedure has 6 main steps. First, and this is our focus, is cannulating the coronary sinus, basically, getting access.
Instead of 1, get in.
Pretty much. Step 2 is performing venograms. That's like taking X-ray pictures of the heart's veins.
Okay.
Third, you select the specific target vein you want and the right lead to use. Fourth is actually placing that lead.
Makes sense.
Step 5 is taking out all the tools you use to get the lead. They're the introducers, guides.
Cleaning up.
Right.
Yeah.
And finally, step 6, you measure all the electrical signals from the leads and program the device. So you see, it's a sequence, but everything really builds on successfully getting that first step done, cannulating the coronary sinus.
Right. Success hinges on step 1. So let's dive into that. Cannulating the coronary sinus. And it sounds like, understanding the anatomy is job 1. Tell us about the coronary sinus itself. Where is it? What does it do?
Okay, the coronary sinus, or CS, it's a major vessel. It sits in the posterior part of the back part of what's called the atrioventricular groove.
The AV groove, like the boundary between the top and bottom chambers.
Exactly. It's kind of nestled in that groove on the back of the heart.
Yeah.
And its main job, it's a vital function really, is to collect the used deoxygenated blood from the heart muscle itself. Think of it as the heart's main venous drain pipe.
The heart's own drainage system. Got it. So where does the blood actually come from before it gets to the CS? What parts of the heart drain into it?
Good question. It gets blood from several key areas. a big chunk comes from the front half of the interventricular septum, that wall between the ventricles,
Okay.
and also from the front wall of the left ventricle, the main pumping chamber. That drainage happens mostly through the great cardiac vein, the GCV.
GCV, right.
That vein runs down the front and then curves around to empty into the CS. Then you also get drainage from the left atrium, one of the top chambers, through smaller veins. And this specific one, called the oblique vein of the left atrium, or the vein of Marshall.
Vein of Marshall, okay.
And finally, the side wall, the lateral wall, and part of the back of the left ventricle drain into the CS too, usually via the left marginal vein. So you can see it gathers blood from a pretty large area of the heart muscle. Understanding that network is key for finding the best spot for the lead later.
That's a lot converging in one place. So when the doctors are actually trying to find this coronary sinus opening during the procedure, what landmarks are they looking for inside the right atrium? Your notes listed quite a few.
Yeah, navigating the right atrium requires knowing the landmarks. There's the tricuspid annulus, the ring around the tricuspid valve between the right atrium and ventricle. Then the fossa ovalis, that little depression in the wall between the atria left over from fetal circulation.
Right.
The Eustachian ridge is important, a tissue fold running from the inferior vena cava opening toward the tricuspid valve. And the inferior vena cava itself, the big vein from the lower body, is a major reference.
Mm-hmm.
You've also got the Thebesian valve, which is like a little flap sometimes guarding the CS opening, the Eustachian fossa, a dip near the ridge, and of course the CS opening, the ostium itself. Knowing how all these relate spatially is crucial for guiding the catheter.
It really sounds like using an internal GPS with all these points of interest to find this one specific, maybe not so obvious opening.
That's a good way to put it. It's precise navigation.
And you also mentioned the middle and great cardiac veins. Why are they particularly significant here?
Well, the middle and great cardiac veins are important because they're usually the most consistent branches. Their location and drainage pattern don't vary quite as much between people compared to some smaller veins.
So they're reliable landmarks within the vein system itself.
Exactly. They help orient you during the venogram later, and the smaller branches draining into the CS. They're usually named based on where they are on the heart's edge, posterolateral, lateral, anterolateral. And there's standard terminology for this, often visualized in an RAO view that's anterior oblique on the X-ray, an angled view. It just helps everyone speak the same language about where things are.
That shared language must be vital, especially given how tricky this step can be. You said earlier that cannulating the CS is often the most challenging part. Why is it so tough, and what are the main ways they tackle it?
Yeah, it often is the crux of the procedure, really.
Yeah.
It's tough because, well, firstly, the opening, the ostium, can be small, and its exact position varies. Secondly, the CS itself and its branches can be quite twisty, making it hard to steer things through.
Right, not a straight shot.
Definitely not. But there are three main techniques.
Mm.
Standard cannulation uses special catheters designed with curves to help find the opening.
Okay.
Second, sometimes they use EP catheters, electrophysiology catheters. They're maneuverable and can sometimes access tricky spots. And third, occasionally coronary catheters, the ones usually used for arteries, might be adapted. It's like having a specialized toolkit, and you pick the right tool for the job, for that specific patient's anatomy.
A toolkit approach. Makes sense. So what's the most common way they initially try to, as your notes put it, fish for the CS?
Yeah. Fishing is quite descriptive. The most common way is using live X-ray fluoroscopy, usually in an AP view straight on or a 30-degree LAO view, angled from the left.
Okay, watching on the screen.
Exactly. Watching the catheter, or maybe a pre-shaped lead, as they gently move it around the right atrium, trying to find that opening. But crucially, they're also watching the intracavitary electrogram.
The heart's internal electrical signals?
Precisely. The signal changes as the catheter tip gets near or enters the CS, so it gives really precise location feedback, complementing the visual X-ray.
Wow, so visual and electrical guidance combined.
Yeah. And if that's tough, they might use phlebography, injecting a tiny bit of contrast dye near where they think the opening is. It outlines the ostium on the X-ray, making it easier to see.
Like highlighting the target.
Exactly. The notes had some good RAO images showing this. You can see the RA lead, the RV lead, and then a catheter successfully in the CS. And others showing the phlebography, filling the veins, really helps visualize what the operator sees.
Those visuals must be incredibly helpful. Now, about those catheters you mentioned, fixed shape ones are most common. Why is that? And you mentioned an example.
Right. Fixed-shaped catheters are the go-to, usually. The main reason is they're preformed curves. They come in various shapes designed to match the typical variations in atrium size and CS ostium location.
So you pick the curve that looks like the best fit.
Essentially, yes. The notes mention the Attain Command catheter as a common example. These catheters give good mix of steerability and support needed to navigate and then engage the ostium. Having different shapes available increases the odds of success.
Okay, adaptability is key. Could you walk us through the basic steps of actually using one of these fixed-shaped catheters to get into the CS?
Sure. So first step, obviously, is getting venous access, putting in a sheath, usually in the arm or neck.
Standard procedure start?
Right. Then everything gets flushed with heparinized saline. Heparin stops clots forming inside the gear.
Okay, important safety step.
Very. Then a dilator goes through the guide catheter to ease its entry into the vein. The whole guide catheter assembly is then threaded over a long guide wire through the sheath and advanced carefully up into the right atrium.
Using a guide wire is recommended, right, for
Okay.
safety.
Absolutely. The notes stress that. It provides a rail, reduces risk of damaging the vessel walls. Once the catheter tip is in the atrium, the dilator comes out.
Okay.
Now comes the fishing part, rotating the catheter tip, usually counterclockwise, pointing it towards the back and left, searching for that CS opening.
Gentle movements, I assume?
Very gentle.
Mm-hmm.
And once they think they found it, they advance the guide catheter maybe 2 or 3 centimeters over the wire to securely engage the ostium and enter the CS. Requires a really delicate touch.
Sounds incredibly precise. And you had a crucial safety point about advancing the catheter itself.
Yes, absolutely critical. You have to be extremely careful. These guide catheters are relatively stiff compared to the vessel walls,
Right.
so there's a real risk of causing a dissection, tearing the inner layer, or even a perforation, punching right through the wall if you're not careful. That's why using the guide wire lead and making slow, controlled movements under fluoroscopy is so vital.
Patient safety paramount, always. Okay, so amazing skill involved. The CS is cannulated. What's the very next thing they need to do?
The next essential step, right after getting access, is the venogram. As we touched on, this is visualizing that network of coronary veins with X-ray, creating the map.
Creating the map. How's that done? What's the process for the venogram?
Typically, they use a balloon catheter. It's got a small inflatable balloon near the tip. They position this inside the coronary sinus.
Okay.
Then they inflate the balloon maybe to about 10 millimeters, often using a specific syringe volume to temporarily block most of the blood flow out of the CS. Sometimes a lead with a wire can do this too.
Like putting a temporary plug in the drain.
Exactly. So the contrast dye they inject before the balloon doesn't just wash away immediately. It flows backwards, retrograde, into all the connecting branch veins, filling them up so they become visible on the X-ray.
Oh, okay. That makes sense.
The balloon can be inflated and deflated as needed, and they usually take images in those standard LAO and RAO views to get a good 3D sense of the vein structure.
So you get a clear picture of all the potential roads, essentially. What's the ultimate goal of getting this detailed map?
The ultimate goal is simple. Identify a suitable branch vein to put the left heart lead into. This map is the guide for step 3. The notes had those diagrams showing typical anatomy in AP, LAO, RAO, and an example of a lead placed in a lateral vein alongside the other leads. That visualization is key.
Leads perfectly into step 3, selecting the target vein and the LV lead. So based on that venogram map, how did they decide where to aim?
The main target area is the left ventricular free wall. Specifically, they're looking for veins running along the lateral side, the posterolateral back and side, or sometimes the anterolateral front and side aspects of that wall.
Why those specific areas?
Well, clinical evidence suggests placing the lead there generally gives the best resynchronization. Those areas are often the last parts of the left ventricle to activate electrically in patients with, say, left bundle branch block. The diagrams in the notes, labeled A, B, C, D, E in the LAO view, illustrate this well.
Right.
A, B, and C, representing lateral, posterolateral, and posterior veins, are shown as preferred targets.
Sure.
D, the middle cardiac vein, and E, the great cardiac vein, are usually considered suboptimal.
So you're trying to pace the latest activating spot to pull it back in sync with everything else.
That's the core idea, yes. Pacing from those lateral or posterior regions usually yields the best mechanical resynchronization and clinical benefit.
Makes sense. So target vein chosen. Step 4 is actually placing the lead in that vein. What makes this tricky? What obstacles might they run into?
Yeah, step 4, placing the lead can definitely have its hurdles. Firstly, just the anatomy itself. Veins can be small, twisty, take unexpected turns, especially further out in the branches. It can be hard just physically getting the lead there. Then there's lead stability. You might get it in a great spot, but will it stay there with the heart constantly beating? Sometimes leads can shift or dislodge,
Oh, right. Didn't think of that.
and achieving good electrical performance is key. You need reliable pacing, delivering the impulse, and good sensing, detecting the heart's own rhythm. Sometimes a vein location looks good anatomically, but the electrical readings aren't great.
Hmm.
And the big one is avoiding phrenic nerve stimulation. The phrenic nerve, which controls the diaphragm, runs nearby.
Hmm.
Pacing too close can make the diaphragm twitch diaphragmatic pacing. It's uncomfortable and needs to be avoided, which can limit where you place the lead.
Definitely want to avoid that. So given those challenges, where ideally within that target vein do they aim to position the tip of the LV lead?
Ideally, the aim is for the middle to distal part of the vein, so further out along the branch, away from the main CS trunk, usually in a posterior lateral branch.
And the thinking there is?
The thinking is to target the region of the left ventricle that has the latest electrical activation naturally. Pacing there should, theoretically, provide the biggest improvement in coordinated contraction, leading to better hemodynamics, blood flow, and better clinical results for the patient.
Gotcha. Targeting the delay.
Exactly. And after placement, they usually keep the patient overnight, do a chest x-ray to double-check the lead hasn't moved.
Okay. So lead is placed. Then steps 5 and 6, remove tools, measure final electrics. Tell us more about measuring those electricals. What are they checking?
Right. Once all leads, RA, RV, and LV are set and the tools are out, they test each lead individually. They measure the pacing threshold, the minimum energy needed to make the heart beat,
Okay.
and the sensing amplitude, how well the lead hears the heart's own signals. But a really crucial test, highlighted in the notes, is testing the LV lead at a high output, like 10 volts,
Why so high?
to specifically check for that phrenic nerve stimulation, the diaphragm twitching. You want to be absolutely sure it won't happen in any likely device setting. If they detect it, they might have to reposition the lead, even if the location seemed good otherwise. Patient comfort and long-term tolerance are vital.
Absolutely. No twitching. Now, what if just sometimes getting that LV lead into the CS system just isn't possible? Anatomy too weird, veins blocked. Are there backup plans?
Yes, thankfully there are alternatives if the standard transvenous CS approach fails. One option is endocardial pacing, placing leads inside the heart chambers.
Inside? How?
Several ways. Transaortic, going backwards through the aorta, transeptal, punching through the wall between the ventricles, transapical, directly through the tip of the heart, or even transatrial via the mitral valve.
Wow, quite invasive options, though.
They can be, yes. Another growing option is leadless pacing. A small, self-contained pacemaker is implanted directly into the LV muscle wall. No leads running back to a device in the chest.
Leadless? That sounds futuristic.
It's becoming more common, definitely a less invasive alternative in some cases.
Amazing ingenuity. Okay, so leads are in one way or another. Now, the device programming. What's specific to CRT programming beyond standard pacemaker stuff?
Good point. While basic pacing and defibrillator functions are standard, CRT has two critical timing parameters that need careful optimization: the atrioventricular delay, or AV delay, and the interventricular delay, or VV delay.
AV and VV delays.
The V delay is the timing between the atrial pacing sensing and the ventricular pacing. Getting this right ensures the atria fill the ventricles efficiently before they contract.
Right, coordinating top and bottom chambers.
Exactly. VV delay is the timing between the right and left ventricular pacing. Adjusting this aims to get the two ventricles contracting together more synchronously.
Making the main pumps work together. How do they set these initially?
Often, they start with default values, known to be general, say, AV delay 100 to 120 milliseconds, VV offset 0 to 20 milliseconds. Or they might use the patient's ECG as a guide, but it's crucial to reassess after a few weeks. Check how the patient feels, maybe do exercise tests, a 6-minute walk test. If they're not responding as hoped, further optimization is needed, often using echocardiography, ultrasound of the heart.
So it's an ongoing fine-tuning process, not just set and forget. Let's dig into that AV delay optimization. What are they trying to achieve physiologically by adjusting that timing?
The main goals for AV delay tuning are several things looked at with echo. One is maximizing stroke volume, how much blood is pumped per beat, often measured indirectly as the aortic velocity time integral.
More efficient pump?
Right. Another is optimizing diastolic filling time, letting the ventricles fill properly. On Doppler echo, you look at the E and A waves of mitral inflow. You want them nicely separated, not squished together or fused, which happens if the AV delay is wrong.
Okay, better filling.
And third, minimizing mitral regurgitation, that backward leak through the mitral valve. You assess that with color Doppler. The trick is, changing the AV delay might improve one thing but worsen another slightly.
Ah, a balancing act.
Exactly. You're looking for the sweet spot that gives the best overall improvement across these factors.
Delicate balance. And what about optimizing the VV delay, the timing between the ventricles?
VV delay adjustments can really impact both interventricular dyssynchrony, the timing mismatch between the ventricles, and intraventricular dyssynchrony, the uncoordinated contraction within the left ventricle itself.
Okay. How do they measure that improvement?
Again, echo helps. Tissue Doppler imaging, or TDI, can measure the mechanical delay in different heart segments. You adjust the VV delay and see which setting reduces these delays the most. M-mode echo, looking at septal to posterior wall delay, is another guide.
So using ultrasound to see the mechanical timing change.
Precisely. And interestingly, some newer devices can actually try to optimize the VV delay automatically based on the electrical signals they sense from the RV and LV leads.
Wow, smart devices.
Technology is always advancing, yeah.
So thinking about the overall success of CRT, what makes a patient more likely to get a good response?
Well, the ultimate goal of the programming, as the notes say, is maximal and continuous correction of that LV conduction delay. Maximal means getting the biggest possible electrical resynchronization. Continuous means it happens reliably, beat after beat.
Makes sense.
This relies on good lead placement, enough energy from the device, consistent pacing, and that optimized AV-VV timing. As for who responds best, numerous big clinical trials, Mustic, Miracle,
Talk about CRT
CART
response. We're looking for
companion
signs that
severe
the
heart
therapy
failure.
is
the
having a
landmark
positive
trials.
impact on the heart structure
And then reverse,
function.
matted George,
This can
Raft,
manifest in
showed
several
benefits
ways,
in milder
including
heart
structural
failure, too.
improvements, functional improvements, and improvements in the patient's symptoms and quality of life.
Okay, let's break those down. What kind of structural improvements might you see with CRT?
One of the most common structural changes is a reduction in the size of the left ventricle. Remember, in heart failure, the left ventricle often gets bigger and stretched out as it struggles to pump efficiently. CRT can help reverse this process, allowing the left ventricle to shrink back towards a more normal size.
So it's not just about getting the heart to beat in sync. It's about actually remodeling the heart itself,
Right.
making it more efficient.
Exactly, and those structural improvements have a domino effect leading to functional improvements as well.
Speaking of which, what are some signs that CRT is improving how well the heart is functioning?
One key measure is the left ventricular ejection fraction, or LVEF.
Okay.
This tells us how much blood the left ventricle pumps out with each beat.
Okay.
In heart failure, the LVEF is often low, meaning the heart isn't pumping as well as it should.
Right.
CRT can help boost the LVEF, indicating the heart is pumping more effectively.
So it's like giving the heart a much-needed power boost.
Precisely. And that improved pumping action has a ripple effect on the patient's overall well-being.
Right, because ultimately we care about how people are feeling.
Uh,
How does CRT response translate into real-life improvements for patients?
well, one of the most noticeable benefits is often an improvement in symptoms.
Okay.
People with heart failure often experience shortness of breath fatigue and swelling in their legs and ankles. CRT can help alleviate those symptoms
Okay.
because it improves the heart's pumping ability and reduces fluid buildup in the body.
So it's not just about numbers on a test. It's about making people feel better and improving their quality of life.
Absolutely. And those improvements can translate into greater mobility and the ability to do the things they enjoy.
That's wonderful.
Yeah.
Are there any other ways to measure CRT response besides looking at symptoms?
Yes, another way is to look at exercise capacity. People with heart failure often have a hard time with physical activity because their heart just can't keep up. CRT can help improve exercise tolerance by giving the heart that extra boost, allowing patients to walk farther, climb stairs more easily, and engage in other activities without getting as winded or tired.
So it's giving them back a sense of freedom and independence.
Exactly. That increased mobility can have a profound impact on their overall well-being.
Well, you mentioned earlier that not everyone responds to CRT equally. Are there any clues that can help predict who is most likely to benefit?
That's a question we're always trying to answer more definitively. There are some factors that seem to be associated with a better response to CRT,
Okay.
including the presence of left bundle branch block, or LBBB,
Hmm.
a wider QRS duration on an EKG,
Okay.
and the type of heart failure, for example, people with ischemic cardiomyopathy,
Okay.
which is caused by reduced blood flow to the heart muscle,
Okay.
often see a good response to CRT.
Okay, let's unpack those. But you mentioned LBBB. Can you remind us what that is and why it might predict a better response to CRT?
Sure, LBBB is a type of heart block that disrupts the electrical signals traveling to the left ventricle. This can lead to that dyssynchrony we talked about, where the left ventricle contracts out of sync with the right ventricle, since CRT is designed to resynchronize the ventricles. It makes sense that people with LBBB who already have significant dyssynchrony might see more benefit.
So it's like CRT is addressing the root of your problem, the underlying cause of their dyssynchrony.
Exactly, and that's why LBBB is often considered a strong indicator that someone might respond well to CRT.
You also mentioned QRS duration. Can you explain what that is and how it relates to CRT response?
The QRS complex is a pattern on an EKG that represents the electrical activity of the ventricles as they contract. The QRS duration is simply the length of time it takes for those ventricles to depolarize or become electrically activated. A wider QRS complex generally suggests more dyssynchrony, as it takes longer for those electrical impulses to travel through the ventricles. Studies have shown that people with a wider QRS duration tend to respond better to CRT than those with a narrower QRS duration.
So the wider the QRS complex, the more out of sync the ventricles are and the more potential there is for CRT to make a difference?
Precisely. It's not a perfect predictor, but it's one piece of the puzzle we consider when evaluating someone for CRT.
And what about the type of heart failure you mentioned that ischemic cardiomyopathy might be linked to a better response? Why is that?
Ischemic cardiomyopathy happens when the heart muscle is damaged due to reduced blood flow, often caused by coronary artery disease. This type of heart failure often involves scar tissue formation in the heart, which can further contribute to dyssynchrony. Studies suggest that people with ischemic cardiomyopathy tend to respond better to CRT than those with non-ischemic cardiomyopathy, which is caused by other factors.
So it sounds like in ischemic cardiomyopathy, that scar tissue might be making the dyssynchrony worse, and therefore CRT can be even more effective in restoring those synchronized contractions.
Exactly. It's not a guaranteed outcome, but it's something we keep in mind.
This is also helpful in understanding the nuances of CRT response.
Yeah.
But I'm curious, what if someone doesn't respond to CRT as expected? Are there other options?
That's an important question, and it highlights that while CRT is incredibly effective for many, it's not a magic bullet for everyone. If someone doesn't respond, or if they initially do, but then their condition worsens, we carefully evaluate their situation to figure out the best course of action. Sometimes it's as simple as adjusting the device programming, tweaking those AV and VB delays we talked about.
So it's about trying to coax the heart into responding better to the therapy.
Exactly. And if adjusting the programming doesn't work, there are other possibilities to explore, like alternative left ventricular pacing sites.
What does that involve?
Traditionally, we place the left ventricular lead in a branch of the coronary sinus that supplies the side or back wall of the left ventricle. But research is exploring the idea of pacing other areas like the front wall or the septum to see if that might work better for some people.
So it's about expanding the options and trying different approaches to find what works best for each person.
Exactly. And on the horizon, we have leadless pacing, which we touched on earlier. These tiny devices are implanted directly into the heart, eliminating the need for those long leads altogether.
That's right. Can you remind us what the potential benefits of leadless pacing are?
Well, without the leads, there's less risk of infection or problems with the lead shifting out of place. Plus, they're implanted directly into the heart muscle, which can make pacing more efficient.
So potentially a safer and more effective approach.
Exactly. Leadless pacing for CRT is still being researched, but it holds a lot of promise for the future.
This field is evolving so rapidly. It's truly remarkable.
It is, and that's why it's so important to stay informed about the latest advancements in CRT and other heart failure treatments.
Well, I've learned so much today, and I'm sure our listeners have too. We've covered a lot of ground, from the fine details of CRT programming to the complexities of CRT response and even the possibilities of leadless pacing. It's been quite a journey.